Welcome back to another episode of ACR Convergence on Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. We continue our coverage of ACR Convergence 2023, where we bring you episodes packed with the groundbreaking science, brilliant ideas, and influential voices from this year's Convergence annual meeting. And today is no exception. We will be discussing the newly released 2023 ACR guideline for the screening, monitoring, and treatment of interstitial lung disease in people with systemic autoimmune rheumatic disease. These guidelines are being presented today at Convergence. We've invited the lead author of the guidelines, Dr. Sindhu Johnson, to bring the guidelines to life and provide us with her insights about when and how to use them. We'll discuss the patient population who is at risk for developing ILD, a population much broader than you would think, which not only includes people with systemic sclerosis, inflammatory myopathies, and mixed connective tissue disease, but it also includes people with rheumatoid arthritis and Sjogren's syndrome. We will discuss how to screen these patients for interstitial lung disease, how to monitor for progression, and first and second line treatments for the management of ILD in these various disorders. At the same time, Dr. Johnson will give us a behind the scenes look at the development of the guidelines, including the involvement of patients in their development, the challenges faced by the writing team, and what these guidelines will mean for both patients and the rheumatologist. Dr. Johnson is professor of medicine at the University of Toronto, director of the Toronto Scleroderma Program, and director of the Clinical Epidemiology Program at the Dalla Lana School of Public Health. Enjoy the show. Sindhu, welcome to the show.
Thank you. I'm excited to be here. Thank you for having me.
It's my pleasure. Let's talk about ILD. What is interstitial lung disease, and why do rheumatologists need to know about it?
Sure. So, interstitial lung disease is an umbrella term for a large group of diseases that cause scarring and fibrosis of the lungs. Now, in the setting of our systemic autoimmune rheumatic diseases, this is primarily led by inflammation that leads to scarring.
Got it. And why is it so important for rheumatologists to be aware of interstitial lung disease? It seems like it's more of a pulmonary issue than a rheumatology issue. Why do we need to know about who gets these diseases?
Sure. So, interstitial lung disease has been recognized to be a major cause of morbidity and mortality, classically with diseases like systemic sclerosis or MCTD. Um, and historically, the term was the CTDs, connective tissue diseases.
Uh-huh.
But we've now moved to a term, systemic autoimmune rheumatic disease, SARD, because we know that the CTDs can include things like Ehlers-Danlos syndrome, and that's
Hmm.
really not the purview of rheumatologists, or not so much. And so, in recent years, we've recognized that ILD is also an important source of morbidity and mortality in other SARDs, like Sjogren's disease and rheumatoid arthritis.
Fantastic. So in 2023, the ACR released guidelines for monitoring and treatment of ILD in people with systemic autoimmune rheumatic diseases. What gap were these guidelines trying to fill?
Well, as I mentioned, that in the last 10 years, we've recognized that ILD is an important aspect of several of our rheumatic diseases, not just systemic sclerosis or mixed connective tissue disease. Around the same time, we've had a number of observational studies, but also randomized trials looking at new therapeutics for the treatment of ILD in our rheumatic diseases. And finally, two of these therapeutics have achieved approval with the FDA. And so
Hmm.
the American College of Rheumatology thought that it would be time to develop clinical practice guidelines for clinicians who care for people with the systemic autoimmune rheumatic diseases who are both at risk for developing ILD as well as those who have been diagnosed with ILD.
Fantastic. So it makes a lot of sense. How did you go about creating these guidelines? Who was involved? What was the process?
Yeah, the American College of Rheumatology has a process for developing clinical practice guidelines, and this incorporates grade methodology. That is the grading of recommendation, assessment, development, evaluation. And so, sort of in a nutshell, there are four phases that require four groups or teams of collaborators. So, step one occurs when a core team identifies what's the scope of the guideline, who are the patients that this guideline is going to apply to, what are the interventions we want to include, what are the comparators we need to consider, and what are the outcomes. So that's the first phase. The
Yep.
second phase, oh, sorry, go on.
No, go ahead.
Yeah. Okay. So the second phase it requires a literature review team, and so they are tasked with doing a systematic review of the literature, grading the certainty of the evidence, and then producing an evidence report for everyone to evaluate. Step three includes a patient panel. The patient panel, in this case, included not only those who are at risk for developing ILD, but also patients who had ILD and a spectrum of experience with the interventions that we are considering.
Huh.
They were provided the evidence report, but more importantly, or equally importantly, they provided their values and preferences that rheumatologists and other caregivers should consider when choosing a treatment. And then finally, the fourth phase is a voting panel. This incorporated a large group of rheumatologists, pulmonologists, both that are academic and community practicing. And they were tasked with reviewing the PICO questions, evaluating the evidence reports, contributing their experience, and then finally voting on the direction and strength of each of the recommendations.
Holy smokes, it's a huge process. Um, do you have any idea how many people were involved and how long did this take?
Sure. So this is one of the largest, if not the largest, guideline produced by the ACR. It incorporated 11 people on the core team, so rheumatologists, pulmonologists, a thoracic radiologist, and grade and literature review experts. The literature review team had 22 people. That is
Wow.
rheumatologists, pulmonologists, and a methodologist. The patient panel had 21 people, and again, reflecting demographics, a range of 71% women, a range of racial ethnicities. And then the voting panel had 27 people, rheumatologists, pulmonologists, or radiologists, and patients. So in total, there were about 79 to 80 people involved in the whole production of the guideline.
Unbelievable. And what how long was that process from the idea about creating these guidelines to, today when you're discussing these guidelines at ACR Convergence 2023?
So the idea, I believe, was submitted to the ACR 2.5 years ago. And then it took about a year to identify who would be the right people to participate at every level of the development, but also considering people's conflicts of interest. Once the core team was assembled, the actual work of guideline development began in April 2022.
Fantastic. So let's get into it a little bit. So the guidelines sort of incorporate two basic phases of ILD. The first one is monitoring. The second one is about treatment. So let's talk about monitoring. What
Sure.
patient population should we think about that may require monitoring for ILD?
Well, in fact, maybe if it's okay with you, we'll step back. It's who
Yeah,
should be screened. So,
love it.
this guideline it applies to people with rheumatoid arthritis, systemic sclerosis, idiopathic inflammatory myositis, mixed connective tissue disease, and Sjogren's disease. The core team felt that of all of the rheumatic diseases, these five diseases are at highest risk of developing ILD. But it was also recognized that across these diseases and within each of these diseases, the risk of developing ILD and then the risk of ILD progression varies quite considerably. So, in terms of who should be screened, it's recommended that nearly everyone with systemic sclerosis and mixed connective tissue disease should be screened because most of these patients will develop ILD, and certainly all of them are at high risk of developing ILD. However, the risk of developing ILD in rheumatoid arthritis and Sjogren's disease is less. And so the core team and voting panel felt that in this situation, it would not be appropriate to recommend screening of every patient with rheumatoid arthritis, but rather a risk based approach should be taken. And so, screening should be a discussion at the level of the rheumatologist and with the patient, and take into consideration potential risk factors. Now, to help with this, the guideline paper will include a table of risk factors that might guide a rheumatologist's decision to screen. And so, for example, in the setting of rheumatoid arthritis, that might include the presence of a rheumatoid factor, CCP antibody, if the patient smokes, has an older age of onset, or high disease activity. Similarly, risk factors for the other diseases are presented as suggestions, but this is not a comprehensive list by any means, and no rheumatologist should feel limited to using this list of risk factors to decide whether a patient should be screened. I think the bottom line is if there is uncertainty about whom to screen, a clinician should proceed with screening.
Interesting. I mean, I was surprised, in thinking about rheumatoid arthritis, that, for instance, you mentioned high titer CCP is a risk factor. So, do the recommendations suggest that patients with, CCP positive rheumatoid arthritis be screened for ILD? Because that is a lot of patients in the United States and around the world.
That's right. And so, no, the recommendation, the guideline does not mandate or necessarily recommend that a patient with rheumatoid factor, I mean, or with an anti-CCP antibody and rheumatoid arthritis must be screened, but a rheumatologist should consider it. And particularly if the patient is symptomatic, in that situation, I would say yes, they should be screened for ILD.
Fantastic. And similarly, I was also looking at Sjogren's, which, rheumatoid arthritis and Sjogren's, at least in my mind, aren't at the highest risks of ILD. But risk factors include lymphopenia, or the presence of Rho52 antibody, which, are present in a lot, similarly in a lot of patients with Sjogren's syndrome. So the recommendations really encompass, a whole chunk of people with rheumatoid arthritis and a big chunk of people with Sjogren's syndrome that I guess are suggested to have screening for ILD.
You're absolutely right. And the literature would suggest that patients with Sjogren's disease who have a Rho52 antibody, ANA, Raynaud's phenomenon, older age, or lymphopenia are at increased risk of developing ILD. And so a rheumatologist might want to consider screening them.
Yeah.
Now, you had asked me about monitoring. And so that's the second group of recommendations that we provide. And so the screening tests are pulmonary function tests and a high resolution CT. And I should qualify that pulmonary function tests is not spirometry alone, but also includes lung volumes and diffusion capacity. These same two tests are also recommended for the monitoring of disease. But what's new that rheumatologists may not be aware of is that in the monitoring of ILD, it's also recommended that patients have ambulatory desaturation testing. This is a test that most rheumatologists do not perform in their clinic, and this is recognized. But rather, I'm highlighting this for you now because while screening may lie in the domain of the rheumatologist, once a person is diagnosed with ILD, we highly recommend co management with pulmonologists. And so, while ambulatory desaturation testing is not part of routine practice for a rheumatologist, it is a regular test done by pulmonologists. And this is to highlight the importance of co management with our colleagues.
I love it because I guess you put in our role to screen patients for ILD with so that the rheumatologist would order the PFTs and the high res CT, and then if there are abnormalities that are suggestive of ILD, to refer those patients to our pulmonary colleagues who can better sort of evaluate their disease, and as you mentioned, help with the monitoring for these tests for desaturation that they can do in their office.
That's right. And, the patients told us loud and clear they value collaborative management between their rheumatologist and their pulmonologist, and they particularly value clear communication. They really don't want to be caught in the middle.
I love it. And at the same time that you have some recommendations, there are some things that you recommend against. Tell me about the role of chest x rays in screening people for ILD, because that's typically sort of first line. What I think about, is getting a chest x ray. I don't even know if, insurance companies require chest x rays prior to undergoing a CT scan to look for ILD?
The core team tried really hard to make these guidelines pragmatic. That is,
Hmm.
address questions that rheumatologists face in clinical practice. And so often, rheumatologists will ask, are tests like chest x ray or 6 minute walk test or bronchoscopy, or even rarely ask, is surgical lung biopsy required for the screening or monitoring of a patient with a systemic autoimmune rheumatic disease and ILD? And so the core team, the evidence, the literature review team, and the voting panel did consider these. And there are tests in this guideline that are conditionally recommended against. So there is a conditional recommendation against chest x-ray, 6 minute walk test, ambulatory desaturation, and bronchoscopy. Now, their caveat is that there may be instances, rarely, where these tests may be considered. So, for example, if a patient with scleroderma has difficulty doing a pulmonary function test, or it's an inadequate PFT because they're having difficulty achieving a good seal around the mouthpiece, well, then one might consider ambulatory desaturation testing as a screening test. Similarly, one may consider a bronchoscopy if you need to rule out infection or sarcoidosis, lymphoma, or alveolar hemorrhage. But the bronchoscopy is not meant to be a screening test for the ILD. There is a strong recommendation against surgical lung biopsy as a screening test or even a monitoring test for ILD. The rare circumstance where a surgical lung biopsy may be required is that you're trying to rule out malignancy.
Got it. And then I have two more questions about this. The first one is in a patient with rheumatoid arthritis or Sjogren's or systemic sclerosis that you screen for ILD with PFTs and high res CT, and it's normal. When or if should these tests be repeated in the future?
Good question. The frequency of screening tests is not addressed in the guideline, but really, our feeling is that a risk-based approach should be taken between the rheumatologist and the patient. So, if the patient has risk factors, then they should be rescreened in the future. Where the guideline does provide suggestions on frequency is for the frequency of monitoring tests once ILD is diagnosed. And so I do want to differentiate the difference between a recommendation and a suggestion. The recommendations are statements for which the evidence has been reviewed and the expert panel has voted on this, taking into consideration patients' values and preferences. And it was felt that this is frequency of monitoring tests was beyond the scope of the guideline. However, it would appear to be a logical question, just like you're asking, how
Right.
frequently should I monitor someone? And so, for that reason, the voting panel did give suggestions on the
Uh-huh.
frequency of monitoring, and so that's provided in the figure or the graphics that accompany the paper. And just to summarize for you, so patients who have idiopathic inflammatory myositis and systemic sclerosis, the diseases with the highest risk of ILD should be and highest risk of ILD progression should have their monitoring tests every 3 to 6 months in the first year, and then
Oh.
less frequency once the disease is stable. Sorry, that should be the pulmonary function test. Whereas rheumatoid arthritis, Sjogren's disease, and mixed connective tissue disease that's not scleroderma predominant, they should have PFTs every 3 to 12 months for the first year and then less frequent once stable. The ambulatory desaturation testing is suggested to occur every 3 to 12 months, and the high res CT is suggested as needed based on patient features.
Fantastic. And, certainly these are very important guidelines. And I'm just thinking of patients that I have in my panel that I should definitely start monitoring with PFTs and high res CT. This is fantastic. Let's
If
move on.
sorry, before
Yeah,
can I just add one sort of clinically relevant clue or
absolutely.
clinical pearl? And so while high resolution CT is recommended, some patients will have a CT angiogram. Let's say they had worsening shortness of breath, they go to the emergency room, and a CT angiogram is ordered to rule out pulmonary embolism. I'd just like to highlight for everyone that a CT angiogram is performed using incomplete inspiration, and that's done to maximize the pulmonary artery enhancement. And so this in turn may produce atelectasis that can either obscure or mimic ILD. So
Hmm.
clinical pearl is that a CTA is often inadequate to screen for ILD. And so a high res CT chest is still required, really to say that a CT angiogram is not sufficient to screen for ILD.
Fantastic. That's a great pearl. Moving on to treatment. There are a lot of recommendations in terms of treating people with ILD that has been identified in our systemic autoimmune rheumatic diseases. How do you sort of think about treatment, approaching treatment in somebody that is diagnosed with ILD?
Sure. So, in the guideline and as well as the summary tables that are available on the ACR website, recommendations for first line ILD therapy are presented by disease. So, systemic
Hmm.
sclerosis, myositis, MCTD, RA, and Sjogren's. Now, in the process of developing these guidelines, the voting panel had to comparatively evaluate two treatments at a time, one versus another.
Hmm.
And so the consequence of that is that we have a hierarchy of treatments that one could consider. The way to think about this is the principle of transitivity. If you know that A is greater than B and that B is greater than C, you can infer that A is greater than C. However, when the voting panel discussed these treatments by disease, it became apparent that the voting panel and the experts don't want to mandate which treatment must be used first, but rather within the list of therapeutic options would consider, there are some that are preferred, but if they can't be used for a variety of reasons, then there are other additional options that one could consider. And so to keep this whole thinking process transparent to the reader and to the practicing rheumatologist, the graphic that we present identifies number one, all the treatment options one could consider, but then we also identify which ones experts would prefer versus which ones would be considered additional options. And so what you might notice is that mycophenolate comes out on top across all five of the diseases. And so experts would strongly consider mycophenolate as their first ILD option. However, if they would consider things like extrapulmonary manifestations, cost, access, toxicity, and so for that reason, the other options are also presented.
Fantastic. Yeah. And, in addition to mycophenolate, I see here on the guidelines, often it's azathioprine, rituximab, and even tocilizumab. And it varies. I think you've done a great job in putting an image so that rheumatologists and patients and anybody else can look at these guidelines and understand sort of the first line therapies, the preferred, as you mentioned, or some additional options. Tell me a little bit about the role of glucocorticoids for ILD, and then in specific how you think about glucocorticoids for ILD in the setting of systemic sclerosis.
Sure. So glucocorticoids are conditionally recommended in the short term for myositis, mixed connective tissue disease that's not scleroderma predominant, rheumatoid arthritis, and Sjogren's disease. However, there is a strong recommendation against the use of glucocorticoids in the setting of systemic sclerosis, ILD, and this is because of the risk of inducing a scleroderma renal crisis. Now, it seems to me that most rheumatologists are aware of the risk that glucocorticoids confer in patients with systemic sclerosis, but this may be new to our pulmonology colleagues. Many of them may not be aware of this. And so here's an opportunity where, when we're co managing patients, perhaps rheumatologists may want to include this in their consultation notes to educate our colleagues that we strongly recommend against the use of glucocorticoids, both as first line therapy as well as use of glucocorticoids in patients who have progressed after first line therapy.
Yeah, I think it's such a valid and important point. I can't say how many patients with systemic sclerosis I've had who go to the emergency department for whatever reason and get diagnosed with a flare of their systemic sclerosis and get put on high doses of steroids, which is always, very, very scary. But, at the same time that you recommend, conditionally recommend glucocorticoids for ILD in diseases except for systemic sclerosis, you're also very clear that you are against long-term glucocorticoids for the management of ILD. So how do you think about the duration with
Well,
those two guidelines in place?
thank you for bringing that distinction up. So you are right. So for first line ILD therapy in diseases other than systemic sclerosis, we do conditionally recommend short term glucocorticoids. However, the converse is well, there's a slight differentiation in people who have progressed after their first line therapy.
Hmm.
So, in the patients who have progressed, there is still a strong recommendation against long term glucocorticoids in patients with systemic sclerosis. And there is a conditional recommendation against long term glucocorticoids in patients with myositis, MCTD, rheumatoid arthritis, and Sjogren's. However, short term glucocorticoids can be considered in those patients as a bridging therapy while you're waiting to access new therapy or while you're waiting for a DMARD to take effect, or if a patient is having a flare of their ILD. But really, we're looking at less than 3 months duration. We really want to limit long-term glucocorticoids should not be considered as a treatment for the ILD, but rather as a short-term bridge.
Got it. And what tell me about what one of the new kids on the block, which is nintedanib, and its role. Where does it fit in this puzzle of ILD for people with rheumatic disease?
Sure. So nintedanib is one of the medications that we have clinical trial data to support its effect in slowing down progression of ILD. And it has received FDA approval for systemic sclerosis associated ILD. And so while it's not recommended as a first line treatment across the other rheumatic diseases, it is recommended as an additional option to consider as a first line treatment in systemic sclerosis ILD.
Hmm.
The voting panel did have concerns, however, about cost and about its adverse effect profile, that notably GI toxicity, including diarrhea and weight loss. Now, in the setting of patients who have progression of their ILD, this is where the voting panel felt more comfortable and conditionally recommended the use of nintedanib across all of the five
Hmm.
rheumatic diseases. Again, the issues of toxicity and cost are at hand, and across the other diseases, the inbuild data that looked at progressive ILD as well as the scleroderma ILD data were both considered indirect evidence for the use of nintedanib across these diseases. So that's sort of one of the new recommendations. The other recommendation that I'd like to highlight for everybody is in the setting of myositis. The
Hmm.
use of calcineurin inhibitors, notably tacrolimus, as well as the use of JAK inhibitors, notably tofacitinib, for the treatment of ILD that is progressing.
Hmm.
Increasingly, pulmonologists and people who see inpatient rheumatology in the ICU are increasingly using these medications for the treatment of progression of ILD. The evidence to support this is less certain, supported by observational studies of low certainty. But nonetheless, this may be new to some rheumatologists. And the other place where I'll highlight these medications is in the grouping of recommendations for rapidly progressive ILD.
Yeah, tell me more about that. So, who
Sure.
are the patients that are at risk of developing rapidly progressive ILD, and then how should we think about their management?
So rapidly progressive ILD is a descriptive term of the modern era. This is a patient who goes from essentially asymptomatic or very mild symptoms to becoming very symptomatic, requiring hospitalization, requiring high flow oxygen over a span of days to weeks.
Hmm.
Usually, ILD is a slowly progressive disease over months to years. So, if you are seeing a patient who progresses quickly over days, weeks, or a few months, you should consider rapidly progressive ILD. And this most commonly occurs in the setting of MDA5 associated myositis. Rarely it can happen in the setting of systemic sclerosis, Sjogren's disease, and rheumatoid arthritis. But the prototypic disease is the patient who has inflammatory myositis with MDA5 antibodies.
Got it. So, yeah, these are I've seen a couple of them, and they can be very, very scary to treat because their disease is just unrelenting. So, how should we think about their management? What drugs should we consider using for these patients?
So, if a patient has severe disease or you have a high suspicion that the patient has anti MDA5 antibodies, there's a conditional recommendation for the use of intravenous glucocorticoids plus two additional therapies. And so, traditionally, we would have used cyclophosphamide, rituximab, or mycophenolate. However, the voting panel had concerns about the risk of concomitant infection or sepsis. Usually, these are the patients we're seeing in the ICU, they're intubated, they may be on pressors. And so, if they were to develop a concomitant infection, the use of cyclophosphamide and rituximab becomes complicated. Or conversely, the use of rituximab or cyclophosphamide may put them at increased risk for an infection.
Sure.
And so the voting panel also conditionally recommended the use of calcineurin inhibitors, IVIG, or tofacitinib. And this is a situation where the use of tacrolimus and IVIG with glucocorticoids is where practice is changing in advance of the data. And so these guidelines reflect this change in practice, even though there is very little data to support this.
Fantastic. And then I noticed that for the rapidly progressive ILD on the image at the bottom, it says, consider early lung transplant referral. When should we think about referring patients for transplant evaluation, in either people with rapidly progressive ILD or other types of ILD?
Sure. So I think, if when it comes to progression of disease, I think if someone has failed their first line therapy, what we conditionally recommend referral for lung transplant evaluation
Hmm.
for at an appropriate time, and to an experienced center. Not everybody will have access to an experienced center, but the patient panel told us that they would be willing to travel if needed to be seen at an experienced center, and that they would value referral. Now, in the setting of rapidly progressive disease, these are patients that really do have poor outcomes, and that the medical management may just be a bridge to transplantation. And so, early referral to lung transplant center should be considered in these patients.
Got it. And you have recommendations about stem cell therapies or stem cell transplants for people with progressive ILD?
That's right. So, similarly, we do not recommend this as a first line ILD treatment option. But if someone is having progression of their ILD, one may consider referral to an experienced center. There was considerable discussion about and comfort with centers, and so this is where the emphasis is put on an experienced center. I just want to highlight for everyone that there were a number of other uh, interventions that the core team wanted to incorporate in the guidelines, but ultimately was felt to be beyond the scope of the guideline. And so in the manuscript, we have a table of other interventions that a rheumatologist and pulmonologist may consider, but is just not included in the guideline. And so these include things like counseling the patient on exercise. We know
Hmm.
that aerobic exercise, resistance training, yoga, tai chi can be helpful to people with advanced lung disease. Similarly, when the time is right, one may want to consider referral to palliative care, particularly for symptomatic treatment, such as treatment of cough, pain, air hunger, as well as end of life planning. One may consider referral to physiotherapy for chest physiotherapy, airway clearance, or counseling on the use of an incentive spirometer. If your center has access to pulmonary rehabilitation, this might be something else to consider. And then finally, discussion with the pulmonologist regarding the need for supplemental oxygen. There were also a few pharmacologic interventions that were beyond the scope of the guideline, but we all include in this table. A rheumatologist may consider the use of proton pump inhibitors and H2 blockers
Hmm.
for gastroesophageal reflux management, particularly if there's concern about nocturnal aspiration. One might consider the use of trimethoprim sulfa for PJP prophylaxis if this patient is on multiple immunosuppressives. One might consider domperidone as a pro-motility agent. And lastly, the ACR recommends vaccination, in particular COVID-19 and influenza vaccination during this time of year.
Fantastic. This was crystal clear, and I recommend everybody to attend the talk on Sunday morning? And also, when are these papers going to be available for readers and for people who are interested in learning more about them?
So there are two summary documents posted on the ACR website already. Both these documents include the tables that list each of the recommendations, as well as the figures that are included in the manuscripts. Sometimes it's easier just to look at a figure to find out what the recommendation is. We recognize that rheumatologists are strapped for time and may not have the time to review the primary papers or the evidence report, whereas a figure can convey the information quite quickly. So that's already available on the ACR website. The manuscripts themselves are currently under review with the journals and are expected to be published in arthritis rheumatology as well as arthritis care and research in the new year.
Fantastic. So, thinking about this whole process, I mean, this was a multi-year with dozens of people involved. What particular challenges did you face in the creation of these guidelines? Were any of them that sort of come to mind as some things that you guys had to overcome?
Well, what I've learned from this is that when you have a clinical dilemma and there are several well conducted randomized controlled trials answering the question, there's really no controversy. The answer is clear. And I don't even think most rheumatologists require a guideline when the answer is clear.
Yes.
I think the role of the guideline is to help to provide guidance to people when the answers are not clear. And so, in the last few years, we've learned that ILD is an important source of morbidity across these diseases. We've also now have a number of potential treatment options. But when you have so many options to choose from, it's hard to know which is the right option or which is the best option for a particular disease. And what I've learned with the American College of Rheumatology is the leadership has recognized that what our membership wants is someone to synthesize the literature for us, to bring the experts together, to bring patients together to weigh in and tell us what does everybody think. And until better evidence or the best randomized controlled trials are available, these guidelines can tell us, well, what do groups of people and experts think?
Great. Yeah, I noticed that a lot of the recommendations are made on very low evidence. So going forward, and discussing with the next generation of rheumatologists, what aspects of ILD do you think should have more research on to try to provide the evidence so that the recommendations become even better and more supported by data.
Well, I think one area of research that's needed is to help us better understand how we define and understand patients who have predominantly fibrotic versus inflammatory versus mixed lung phenotypes. And the reason I say this is that clinicians are increasingly using the radiographic pattern reported on the high res CT chest, that is, NSIP pattern or UIP pattern, to guide therapeutic decision making. And there, as an example, there is a belief that if a patient with rheumatoid arthritis (ILD) has a UIP pattern, perhaps they would be better off being treated with a so-called antifibrotic medication.
Hmm.
And so I feel like that the next group or the research is needed to see, is this true? The other area of research that's needed is the use of predictive biomarkers. It
Hmm.
would be nice to better identify who are the patients that need to be screened, who are the patients that need to be more frequently screened, who are the patients that need to be more aggressively treated. And a good example of this was the identification of the MDA5 autoantibody. We now
Hmm.
realize that this particular autoantibody gives clinicians information that's different than other autoantibodies. And so I think research is needed to help move that field forward.
Fantastic. And how do you think what should we do going forward in regards to these recommendations? I mean, this took a lot of work. How do you think about updating these recommendations in the future when we have, that data that you just mentioned about who to screen, biomarkers, more effective treatment? How do you see this going forward?
So I think the American College of Rheumatology is trying to move towards a living guideline model. And
Hmm.
so I know our core team is committed to reviewing the literature annually to
Wow.
see if there's any new evidence. However, the ideal situation is that When new evidence is published, in particular, evidence that would change the strength or direction of recommendation, this would be updated in real time. And so that would be the goal over the next few years if we can move towards a living guideline model.
Sindhu, anything else that rheumatologists need to know about these guidelines?
Well, a unique aspect of these guidelines is the risk based approach. That is, assessing an individual's risk for developing ILD to inform screening, to assess a patient's risk of progression to inform monitoring, and then taking patients' extrapulmonary characteristics, access considerations, as well as preferences and values in the choice of treatment. Now, I think most rheumatologists will feel comfortable with this because we're used to operating in shades of gray. And it's the culture of our specialty to take into account patients' values and preferences. But the one cautionary note that I would like to highlight is that the hierarchy of treatments that we present as both first line treatment as well as treatment for progression of disease should not be used by insurers to mandate a specific order of prescribing. Clinicians must retain the latitude to prescribe medications based on individual patients' factors and preferences.
I love it, Sindhu. And I really commend you for this incredible work, trying to manage so many people over years and creating, two documents that are actually very readable and understandable, even for people that don't do this, day in and day out, both in terms of, thinking about screening for ILD, how to screen, how often to screen, and more importantly, treating these patients with various different agents depending on their disease, and certainly working with our pulmonary colleagues to make it all happen. Thank you so much for your time here and for all the dedication that you've done, over the past couple of years in leading these guidelines.
Oh, thank you so much for having me, and thank you for sharing this work with everyone who listens to your podcast.
Well, there you have it. The new 2023 ACR ILD guidelines that recommend the screening for interstitial lung disease in a large chunk of the patients that we see in clinic every day. Hopefully, these guidelines will allow us to detect the early development of ILD so that we can provide more effective treatments, prevent morbidity and mortality, and in doing so, improve patient outcomes. Don't forget to tune in to ACR Convergence on Air every morning starting Saturday, November 11th until Wednesday, November 15th for a rendezvous with innovation, inspiration, and invaluable insights. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, let's order those high-res CTs and PFTs for our patients at risk. And of course, stay healthy.